This is a one-sided, intense, sharp, and stabbing, almost electric shock-like pain in the face. Roughly 15,000 new cases in the USA each year. Women are 1.5 times more likely to suffer from this disease. Stay tuned to learn more about this painful disorder.
Welcome to Region Med 101 podcast with Dr. Yu. Learn about all things medicine, health, and wellness. We hope you enjoy listening. Please show your support by subscribing and follow our podcast.
Trigeminal neuralgia, also known as facial pain, also known as tic douloureux. For the remainder of this podcast, this condition will be referred to as trigeminal neuralgia. Trigeminal neuralgia is a one-sided facial pain that is characterized by brief, painful episodes of intense, sharp, shock-like pain in the face, and it's along the nerves of the trigeminal nerve, also known as cranial nerve 5. Anatomy-wise, cranial nerve 5 has three main branches, V1, V2, and V3. V1 is the ophthalmic nerve, and it carries sensory information from the scalp and forehead. V2 is called the maxillary nerve and carries sensory fibers to the lower eyelid, cheek, nose, and upper lip. V3 is called the mandibular nerve and carries sensory fibers to the lower lip, lower teeth, chin, and part of the jaw. Trigeminal neuralgia is a rare disease. In the US, 15,000 new cases each year. Females are more likely to have trigeminal neuralgia, and the disease can occur at any age. However, 90% of cases happen after 40 years old. There are three types of trigeminal neuralgia variants. They include classical trigeminal neuralgia, symptomatic trigeminal neuralgia, and idiopathic trigeminal neuralgia. I would like to now present Dr. Nguyen, emergency medicine resident at Conemaugh Medical, who will discuss the three different variants.
Classical trigeminal neuralgia is the most common variant trigeminal neuralgia variant. In classical trigeminal neuralgia, there is no apparent cause, but researchers believe that the facial pain is due to some compression of the trigeminal nerve by either an artery or vein that is nearby. This compression can lead to twisting of the trigeminal nerve, a condition called focal demyelination, which means the myelin sheath that helps electrical signal get transmitted across the nerve fiber is damaged, and other microscopic changes. Even a light touch of the face or a breeze of air can lead to extreme pain. Physiologically, it is due to fast myelinated A-beta fibers that activate a slow nociceptive A-delta fibers and leads to a high-frequency discharge, thus leading to the sharp shock-like pain. Symptomatic trigeminal neuralgia is strictly caused by some known structural lesion or compression from a tumor, or due to a deformity of the artery and vein called an arteriovenous malformation, or from a disease like multiple sclerosis. Finally, idiopathic trigeminal neuralgia is due to some unknown factor that is not found pathologically. Idiopathic means the condition arises spontaneously.
How does the disease progress? Trigeminal neuralgia can enter complete remission in more than 60% of patients suffering from it. Complete remission means that tests, physical exams, and scans show that all signs of the disease are completely gone. In multiple sclerosis, roughly 2 to 3% of patients will develop trigeminal neuralgia. Physicians suspecting trigeminal neuralgia is usually signaled by the patient's history and symptoms. Physicians should distinguish facial pain from other causes. Most patients will develop unilateral symptoms. However, sometimes bilateral symptoms can occur. These generally occur in individuals diagnosed with multiple sclerosis. Pain strictly follows the distribution of the trigeminal nerve branches and does not extend to the areas outside of the trigeminal nerve distribution. For instance, there should be no pain in the back of the ear or the angle of the mandible, as these areas are innervated by the C2 nerve. Furthermore, stimulus-evoked pain is the main feature of trigeminal neuralgia. Light touch, breeze of air, shaving, application of makeup, brushing teeth, eating or drinking, or even simple things like smiling or talking can cause paroxysmal pain. Sometimes small facial muscle contractions such as tics can be reported. A full neurological examination of the head and neck should be performed, focusing also on the ears, mouth, teeth, and the temporal mandibular joint for other organic causes. However, the pathognomonic sign for trigeminal neuralgia is a finding of trigger areas near the perioral face causing sharp and shock-like pains in the distribution of the trigeminal nerve. Imaging. High-resolution MRI will help determine if there is a neurovascular compression and confirm any morphologic changes of trigeminal nerve root for classical trigeminal neuralgia. MRI can also identify tumors or even multiple sclerosis plaques as a diagnosis of symptomatic trigeminal neuralgia. Other tests. For patients that cannot undergo MRI, a neurophysiologic recording of the trigeminal reflexes can differentiate classical trigeminal neuralgia from secondary trigeminal neuralgia. However, these tests can cause severe pain and frequently, patients may stop the test prematurely. Outcomes and consequences. Recurrence, or happening again, is associated with being female, symptoms of facial pain lasting more than 8 years, and confirmed compression of the trigeminal nerve by a vein, or after a surgical intervention, facial tics and spasms that just do not immediately stop. Physician managing trigeminal neuralgia should also keep in mind changes in location, quality, and severity of pain, as this can lead to other diagnoses and require different treatment plans. Treatment. Trigeminal neuralgia is treated with anti-epileptic medications. First-line medication is carbamazepine or oxcarbazepine. Second line, especially for refractory cases, other anti-seizure medications may be tried, including baclofen, valproate, lamotrigine. Other antispasticity medications like tizanidine and topical capsaicin have also been tried. Stages of trigeminal neuralgia. At the time of this podcast, no true distinct disease stages of trigeminal neuralgia exist. Most of what we know is how patients present. Other treatment options. First and foremost, making sure nothing in the environment is triggering the trigeminal neuralgia. For instance, some known trauma or pressure on the face while you're sleeping, or a previous car accident to the area. After environment has been checked, medication management should be tried. Having complementary and alternative treatments like acupuncture and relaxation techniques and medications should also be added to improve treatment for trigeminal neuralgia. Also, if eating and drinking triggers the trigeminal neuralgic pain, having a nutritionist help with optimizing nutrients intake in patients is absolutely key. If conservative treatment has failed, there are interventional treatments that can be performed by a licensed and fellowship-trained pain physician and/or a licensed neurosurgeon. I would like to bring back Dr. Nguyen to discuss the different interventions offered for trigeminal neuralgia.
Interventional treatments for difficult to manage or severe trigeminal neuralgia has 4 categories. Number 1 is peripheral techniques. These include cryotherapy, neurotomies, alcohol injection, phenol injection, peripheral acupuncture, radiofrequency ablation, thermocoagulation, with the target being the trigeminal nerve distal to the Gasserian ganglion. Number 2, percutaneous Gasserian ganglion. Interventions targeting the Gasserian ganglion using radiofrequency thermocoagulation or percutaneous glycerol rhizolysis or balloon compression. Number 3, gamma knife radiosurgery. This uses a beam of radiation to target the trigeminal nerve root, generally for patients that cannot undergo surgery due to having blood coagulation problems, like patients being on warfarin. Number 4, posterior fossa microvascular decompression of the nerve or artery or vein with or without destruction of the Gasserian ganglion. Of note, the gold standard surgical technique for treatment of classical trigeminal neuralgia is microvascular decompression. Of these 4 categories of interventions for trigeminal neuralgia, a separate category of peripheral nerve stimulation has been shown some good evidence for difficult to treat trigeminal neuralgia. This method uses an electrode being placed underneath the skin and having electrical signals stimulate the area. Other newer techniques currently being studied are deep brain stimulation, which uses electric stimulation in structures deep in the brain by using an implanted pacemaker.
The most common variant of trigeminal neuralgia is the classical trigeminal neuralgia. It is an extremely painful condition with the majority having complete remission about 60% of the time. For those that continue to suffer, medications, complementary and alternative medications, as well as pain interventions, and finally surgical options may be offered. I would like to thank Dr. Nguyen for her contribution to our episode on trigeminal neuralgia. Please listen to RegenMed 101 interview series with Dr. Nguyen to learn more about her medical background and interest in pain management. I would like to bring Dr. Nguyen back to discuss her own experiences with trigeminal neuralgia.
Even though I have never experienced trigeminal neuralgia myself, I have seen countless of patients in this condition in the emergency room. In addition, my father also suffers from this condition since 2009. When we first knew about it, we did not understand why it happened and how it happened. I was a pre-med at a time, and the concept of trigeminal neuralgia was very foreign to me. I do feel that this condition is not well explained to the general public, and I'm hopeful that this podcast will significantly contribute to general public's knowledge. Talking about my dad, these episodes are usually triggered by cold weather, chewing, and certain type of food. He was initially placed on carbamazepine, which is an anti-neuroleptic medication. Initially, the medication helped significantly. However, throughout the years, the medication does not work as well on him, and he has to up his dosage. He underwent MRI imaging, and they were not able to identify the location of nerve, artery, or vein compression. His condition is idiopathic trigeminal neuralgia. Due to an unknown cause, he cannot undergo nerve decompression. My dad does say that avoiding a certain type of food, keeping his head from getting too cold, or chewing slowly can help with the symptoms. However, it does not go away. His condition is being managed with medications and avoiding trigger. Finally, thank you Dr. Yu and RegenMed 101 for having me take part in this episode. Please subscribe and listen to my future episodes on RegenMed 101.
Knowledge is power, and it is the first step in knowing your condition, disease, or injury.
If you enjoyed listening to our podcast, please visit our Instagram, Twitter, and Facebook. For more detailed information, please visit our website at regenmed101.com.
This podcast is made for the general education to the public and is not intended to substitute for or provide medical advice. All information, content, and material from Dr. Yu and his guests on RegenMed 101 is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician. Please see podcast and page content for full disclaimer. If you have a medical emergency, call your doctor or 911 immediately.